Hello and welcome to Ortho Art. My name is Khalid Al-Awadi. I am a final year medical student at Kuwait University. Today we'll talk about the orthopedics knee examination. So these are my references for this presentation, and hopefully you will enjoy this presentation. So a quick disclaimer, as I mentioned to all of my previous videos, so this is intended for clinical year medical students at Kuwait universities. So for all medical students worldwide, please adhere to your local medical school guidelines on examination and clinical skills prior to watching this video. And I'd like to thank very much Kuwait Medical Student Association, KuMSA, and part of it the Standing Committee of Medical Education and the Clinical Years Subcommittee for their amazing job and contribution for clinical years medical students to excel in their exams. So before I go and continue the presentation, please make sure to check out the description down below if you want to check out the timestamps for this video. If you wish to go to a different part of the videos, please check out the description down below. And let's begin. So start first with the table of contents. We're always gonna start, as always in orthopedics, case scenario, an examination. Then we start with our always look, feel, move, neurovascular status, special movement, and then we'll end with common questions that you might be asked during this examination station. So first we start with the case scenario. So this is a 37-year-old footballer. He is actually very famous and known between footballers as a Swedish striker. Present to you at the outpatient department sports clinic with right knee pain and limping after a football match. After checking proper history, please examine this patient in an orderly fashion according to his main complaints in 7 minutes. So I'll show you the video of how the injury happened prior to the visit. So as you can see from the video, that he landed awkwardly on his right leg while he was trying to get the ball from his teammate while he's passing with a long pass, and he tried to jump. However, he landed awkwardly. So this is the video. You see how the scenario happened. So he injured his ACL and meniscus, the lateral meniscus to be specific. Now he's cruciating pain because it's a very painful injury, the ACL injury. So this is his operation post-operative. This is from his Instagram. So he had a surgery. So this is an arthroscopic plus meniscal meniscectomy, lateral side, and with it he had a ACL reconstruction, as you can see from the graft. So this is one of the scars that he used for the grafts of the new ACL, and he recovered, and he's doing a very good job at the age of 38 years old, which is usually unlikely for a footballer to play at this age. So this is a type of structure that he injured. So this is the ACL, and this is the meniscus. He injured this side specifically, according to reports. So for the anatomy, as always, you have to know your anatomy very well as you'll be examining during or after examination, plus it's clinical significant. Some of it I'm gonna mention it in the neurovascular status slide. However, you need to know your anatomy very well. So in any examination settings, we always start with wash, introduce yourself, permission, exposure, wipe, look, feel, move, neurovascular status, and special tests. These are very important in every orthopedic examination. So a quick tip before going to the exam station: always make sure to comment what will you do in every step as we go throughout the examination, and especially in any surgery examination station. Orthopedics, urology, vascular examination, general surgery, etc. It differs from medicine. Medicine, sometimes most of the time they'll ask you to examine this patient and tell me the findings at the end of the examination, without telling you the steps, unless because of the time. So because of the COVID-19, always practice with your colleague and your family member. Make sure you have a family member to help you with the examination, and you apply the clinical practice and knowledge, and to it will help. Start first with wipe. So as always, wipe, wash your hands, introduce yourself to the patient examiner, ask the patient for permission for examining his knee. I'm going to perform a knee examination, which involves examining your knees. Is that okay? Then you ask the patient to expose his knee, expose from the groin to the toes, to expose for the proper exposure of the knee examination while he's standing. Then we start next with look. Look is from two categories: inspection and gait. So we'll start with the inspection. So while the patient is standing, you make sure look at the legs from front, side, and back. And always in any orthopedic examination, always look at the patient while he's standing. Always. So what do we look for? Look for skin. Check for the scars. So as I showed you earlier, the after the surgery he had a small scars called an arthroscopy scars for ACL reconstruction. As you know, in the past, in the 80s and the 70s, the ACL was treated with an open surgery, like you're doing a total knee arthroplasty, which I'll show the scar in a few seconds. However, today they treat it with an arthroscopic scar, which is a small scar, like almost a less than 1 centimeter size or length of the suture. Then you check for the wounds resulting from trauma. Let's say if you fell from your bike, you fell during a football match, and you start to have a wound. So you have to always treat it as quick as possible to avoid an infection. Then you check for erythema. Let's say an example of infective osteomyelitis of the knee, or infection of the knee, for example. That the knee you have swollen and you have erythema. Then you have a rash, which is a silver scaly skin you can see on the extensor surfaces. So this is a scar from a 72-year-old lady who she had a left total knee arthroplasty, which is basically a surgery to replace all the joints because of osteoarthritis. So you remove all the abnormal joint and you place it with the prosthetic joint. So this is a scar. Usually the scar is usually like this, or sometimes longitudinal. Then you check for swelling, whether it was localized or diffuse. Always for swelling, you check for two things: effusion at the patella, and at the back of the knee, you check for the popliteal fossa, for popliteal cyst or Baker cyst, which I'll show you in a couple of slides. So this is the patient's knees. So as you can see, the patella, this is a normal patella. So as you can see, the groove or the dimples are present here because of the knee is normal here. Whether in this patient who had the right knee fusion, the dimples are almost disappearing or gone, as is shown here, because of the effusion. This is how you can know this patient if he has a effusion or not. You like to check the dimples of the medial side of the patella. Then you check for muscle atrophy. However, you're not required to measure. You're not asked to bring a meter and a measuring tape to measure the thigh or leg circumference, especially the two muscles, the vastus medialis oblique muscle, VMO, and the quadriceps muscles. So the quadriceps contains this type of muscles. The quadriceps contains of these four muscles. These muscles are responsible for the knee extension and help. Now we'll focus on the vastus medialis oblique. Why is it very important, this muscle? Because this muscle, alongside the medial patellofemoral ligament and with the trochlear groove, are responsible for patellar stability. They are very crucial and important. If, let's say, any abnormality occurred in one of the three structures circled in blue, this may lead to any patellar instability, and you have to investigate and treat this patient. And these are the quadriceps muscles: the rectus femoris, vastus intermedius. Usually it's deeper than the rectus femoris. So as you can see from the anatomy, the superficial one, so this is the rectus femoris, this is the vastus medialis obliques versus lateralis. The intermediates will be deeper than the intermediates will be deeper than to the rectus femoris muscle. Next, we'll check for asymmetry. Well, let's say a patient had an injury to tibial fracture or fibular fracture. You have to, when you repair the patient, you have to make sure that one leg is equal to the other. Or sometimes an injury, the ACL injury or a PCL, you have to check if the cause is a knee or a hip. So always you have to investigate, as mentioned earlier in the hip examination. And check for fixed flexion contracture, which I'll talk about it later on in one of the slides. So in inflammation or infection. So fixed flexion contraction means a loss of extension. This patient has a loss extension to a certain degree. Posture or standing leg alignment. So when the patient is standing, you check at the joint position from the knee, which it was neutral, varus, valgus. Now it's whether it was a frontal plane, sagittal plane, and then you check that the patella face up straight, which I showed you earlier. The main structures should help and maintain the patella facing up straight. Now for the frontal plane, you check for genovalgum and genovarus. Now for the frontal plane, you check for genovalgum, which is the knock knees. If noted, you have to check for the intermalleolar distance. So you measure between the distal malleolus of the foot between each measurement. And in an ideal situation, and after age 7 should be less than 8 centimeters. If more than 8 centimeters, it means you have a problem, or you have most likely you have a genovalgum, and you have to investigate. When you say a bilateral, usually where you can see the bilateral genovalgum in rheumatoid arthritis, osteodystrophy in pediatrics age group, or can be a physiological at the age of 2 to 3, and which can be corrected by the age of 6 years because of the bone is forming. Unilateral when you have a facial injury and trauma. That's why I told you earlier to check for asymmetry, vascular infection insult. In genovarus or a bowel lignus, you check for an intercondylar distance, so a distance between the knees. In a male, it should be less than 4 centimeters. In female, it should be less than 5 centimeters. And what you can see commonly in osteoarthritis, it's very common you see in osteoarthritis to see a genovarus in the clinic. A Paget disease or a Ricketts disease. Ricketts disease, you see it very commonly, you see it in pediatrics age group. When you do a pediatrics rotation, you have at least to encounter at least 2 to 3 cases of Ricketts disease. Why? Because the patient usually on breast milk, and not breast milk for a long time, or the feeding problem that causing to lose calcium, causing problems of this deformity, Ricketts disease, and you always have to investigate and advise the mother to change the diet of the child. Then you check for the patella, and then it should face up straight. And finally, we end up with gait, to an antalgic gait or patellar tracking, and check for a flexed knee gait, which I'll show you later on, and a muscle weakness. You have a problem with gait later on. This is most of it I mentioned it in the hip examination, so feel free to go back to the hip examination video and check out the gait section. So this is the muscles we mentioned earlier regarding the stabilizers, the patella. Now this is the deformity we may encounter in the clinic. So this patient has a knee recubertum and a knee genovarum, which was corrected, and thankfully she started to have a normal alignment of the knee. So this is a small mnemonic. We usually tell the students, you remember the L. L is a valgus, or sometimes we tell a genovalgum. Valgum as in a gum. Recubertum is going back knee. Varum is bone knee. So when the knees are bow legs, always check for genovarum. In a bow legs, always you have to check for intercondylar distance, which is you measure it from the medial condyles of both knees. And knock knees, you have to measure for intermalleolar the distance for the knock knees. Check how many centimeters. You're not required to measure it. Just if you see it, just if you notice in the exam this patient had a bow legs or a knock knee, that I can see there is a this is a deformity of a bullocks. How, and I would like to measure the intercondylar distance. I'll ask you to move on. And then one of the swellings you have to examine, other than the patellar swelling, you have to check for brachial cyst, which is here at the posterior side. So always palpate. You have to always palpate and check for brachial cyst. And always check where the issue is. So in the bow legs, usually the problem is the patient, the axial weight will be most likely in the bow legs in the medial condyle, causing the problems with the joints. So you'll lose the joint space. You have contractures later on and problems later on. In a knock knee, the axial load will be most likely in the lateral condyle of the knee. So this is the flex knee gait, which I mentioned earlier. So this patient had a ACL tear recent, and this you'll notice a gait, the flex knee gait. And with the patient on examination, they found out they had interarticular swelling because of the ACL. As you know, ACL tear can cause hemoarthrosis or interarticular bleeding into the joint. So you have to check, not always. And then the quadriceps and the hamstring co-contracted to stabilize the knee because of the ACL injury. So the abnormality you notice on the left knee. Okay. Then we proceed with feel. So always before you palpate or touch the patient, ask the patient, do you have any pain in your knees? I apologize, this is a typo. Always ask the patient if you have a pain in your knees. Trust me, if you mention the exam, at least you have a grade for being professional to the patient. If you palpate the patient and he's in pain, this is not a good sign. The examiner will stop the examination and he may fail you. So always be careful at this point. So in palpation, what do you want to palpate for? Check for the temperature with the back of the hand. Check the back of the hand from the quadriceps, and then compare both sides until the thigh. Check for joint line tenderness, which I'll show you later on in the video. And then tenderness of the medial patellar facet or medial patellofemoral ligament, which I showed you earlier as one of the main stabilizers. Because if you tear it, it may have tenderness, and patient patellar tracking will be abnormal. And then check out the tenderness of the soft tissue structures. An example of that is the pes anseris bursae medially, or a hamstring conjoint tendon insertion, or IT band laterally. There is also tendons of Gabel extensor mechanism, as I mentioned. The quadriceps tendon help in the patellar and knee extension at the patella. Check the patellar tendon and check also the tibial tuberosity, because of one of the insertions of the knee extension is placed in the tibial tuberosity. We also palpate the patella for tenderness crepitus. If it's a crepitus, means there's an arthritic changes. Mobility, position, and we always mention the patella should face upside, should not go laterally. If it went laterally, means a problem. You have to examine with special tests, which I'll mention later on. Effusion. So you do a patellar ballottement test for larger effusion. You already did that in third year. However, I'll mention it again, so you have to do it. So the patient in a supine position with the knee fully extended, you have to press on the patella into the posteriorly, and you have to release quickly. Observing for rapid rebound, indicating increased fluid pressure. When you compress the suprapatellar, ideally when you do it, you have to make sure you compress the suprapatellar pouch. So you press from the medial side going to the patella to superior suprapatellar pouch, and then you press for the increased knee effusion. I'll show you in the video. The fluid wave or ripple test or milking test for small effusion. Patient lying in a supine position as the knee full extension relaxed. Milk the fluid upwards on the medial side, suprapatellar. So it's then milk the fluid back down laterally for unwatched fluid wave. Usually it is in the small and medium. However, for large effusion, always do a ballottement test. Now I'll show you the video of the palpation.
But also allows us now to palpate all of the anatomic landmarks around the knee. We'll palpate along the quadriceps tendon, its insertion onto the patella, the patella itself, the distal pole of the patella, which we can maximize by pushing down and having the patella tilt up and pushing at the very distal part, which would actually be sensitive if they had jumper's knee or tendonitis of the patellar tendon, or the tibial tubercle at the insertion of the patellar tendon, which would be positive if somebody had Osgood-Schlatters disease. We can also evaluate stability of the patella by moving it from side to side but reaching underneath to evaluate for arthritis or degenerative changes on the medial facet or lateral facet of the patella. Next, we'd actually be able to palpate anteriorly along the medial border of the patella, the medial patellofemoral ligament or medial plica, which is a small band of tissue that runs from the mid portion of the patella to the medial epicondyle. And if you pull backwards and forwards, you'll actually feel a worm-like structure, and if that's symptomatic, that can be a source of their pain. The hamstring tendons begin from medially and insert about 3 finger breadths below the medial joint line onto the medial aspect of the tibia. This pes anserine insertion can be a source of pain and bursitis. On the lateral side of the knee, the iliotibial band inserts onto a bump called Gerdy's tubercle and can also cause pain in that area. More commonly, the iliotibial band at the knee will hurt directly over the lateral epicondyle. If we can have our patient lay sideways, here we can get a visualization along the entire IT band. The IT band's coming down to Gerdy's tubercle. If I put my thumb directly over the lateral epicondyle, oftentimes that's not painful, but when I bring the leg into extension, the IT band falls from posteriorly to anteriorly underneath my thumb and exacerbates the pain of IT band syndrome at the knee.
With the patient supine, the examiner presses one hand over the suprapatellar pouch and gently pushes downwards. The examiner taps gently with the thumb or the fingers over the patella. The test is positive if the patella floats or bounces back after tapping.
So it's a little different to the look, feel, move that you may be used to, but I think this is a good start to finish way to examine the knee. So a fusion, we're doing a swipe test. We swipe upwards, pushing any fluid up into the suprapatellar pouch, and then we swipe down on the outside, looking for a bulge in the medial knee here. So swiping up and then down the outside, swiping down. We can also palpate for an effusion. Sometimes a larger effusion, you don't have such a nice swipe, so we can see, is the knee feel full relative to the other side?
Okay. Then we proceed to move. So before you perform passive range of motion fidget, ask the patient, do you have any pain on your knees or the hip? Yes? No. Always don't forget to mention that again. So always examine both sides. Make sure you examine both sides in hip, knee, and shoulder. You always examine both sides. So start first in the knee. So the knee there's always 2 movements: the flexion and extension. So ask the patient to bend his knee to his chest, then straighten his leg bad while he's on the bed. Then place your hand on the extended knee and try to flex the knee with your left hand, holding the knee to feel for crepitus, and the right hand holding the lower leg of the tibia. You ask the patient to lift up his leg with his knee straight. Don't forget that. If unable to perform this movement, it means there is a problem with the extensor lag is present. So you have to investigate. Now I'll show you this video.
Assessing movements of the knee, both sides must be compared. Observe active movement, and then evaluate passive movements if appropriate. Examine extension of the knee, followed by flexion as shown. The normal range of motion is between 0 and 140 degrees, but this varies between individuals. One hand can be put over the joint to feel for any crepitus during passive and active movement.
Okay. Then you check for neurovascular status. So you have to examine each nerve and its function, and always check for examine both sides. So in the knee, you always have to examine for obturator nerve, the femoral nerve, the sciatic nerve, the peroneal nerve, and the tibial nerve. Why? So we'll talk about the obturator nerve first. As you can see, it's innervates the medial thigh. So I basically made this table just to summarize everything regards to the nerves to make it easier for you to memorize the nerves and to understand how the neurovascular examination of the knee works. So the obturator nerve, so it innervates the medial thigh. For the motor, as you can know, the obturator nerves, it comes out of the obturator foramen, which is on the lateral side of the midline of the pelvis. So an obturator foramen, you have the medial muscles, so it innervates the medial sides of the muscle, so, and innervates the adductors as a result. Because in the thigh you have medial, lateral. In medial, they always the medial side of the thigh. Their job is to adduct. It's always what it was obturator externa, adductor longus, adductor brevis, adductor magnus, and gracilis. Their job is just to do adduction. And then you have a femoral nerve, which is sensory to anterior thigh. So the innervates the anterior thigh muscles, the pectineus, iliacus, serratorius, and it can also innervates the quadriceps femoris, which I mentioned earlier. So their job is basically to do a knee extension, as I mentioned earlier, for the quadriceps femoris, and for the anterior thigh muscles, it's hip or thigh flexion. So always ask the patient to do these movements, and you do it against resistance, as always. And you mentioned examine. I would like to examine the check for the obturator nerve. So you measure the sensory with the cotton, then with a neurological pen. Then ask the patient to do a motor movement, and what is ideally should be done. So with the obturator nerve, you mentioned to examine like the obturator nerves. It innervates the medial thigh, and its main job to do adduction. So ask the patient to do a thigh abduction, and it innervates these muscles. You have to mention all these. Unless the examiner tells you to skip, and he might be asking you at the end of the examination or after you finish the exam, you might be asking about the nerve and its clinical significance. Now with the sciatic nerve, from its name, sciatica, the injury, it innervates the posterior lateral cuffs. It's one of the largest nerves in the body. Don't forget that, and it innervates the posterior thigh muscles, the biceps, biceps femoris, semimembranes, and semitendinous, and the hamstring portion of the adductor magnus, and it's responsible for knee flexion. Now for the perineal nerve, it innervates the dorsal foot as sensory, and is responsible for the muscles of the anterior compartment of the leg. Why? It helps for the foot dorsiflexion and toe extension, and it's one of the nerves responsible for foot drop, in which basically the foot dorsiflexion is lost, and the patient will be basically dragging his leg, unable to do a dorsiflex to perform the step, the downward step, as a normal human being would do. And finally, you have a tibial nerve. It innervates the plantar foot, and it innervates the flexor hallucis longus and flexus digitorum longus. Flexor, flex, longus, long muscle, hallucis and digitorum, and both of them are part of the toes. For the hallucis, from its name, it responds to rectoflexion and plantar flexion. The flexor digitorum, the toes, do the flexion and the plantar flexion. So this is basically a neurovascular status summary. And also you have to always palpate for the popliteal pulse. It's difficult to feel unless you suspect popliteal aneurysm, and you do it in a scoop fashion. So you place your thumbs on the tibial tuberosity, and then you do like a scoop. So you put your fingers behind the knee, and you have to dig in deep. It's like as you're scooping an ice cream, and you palpate very deeply to palpate for the popliteal artery. It's difficult to feel. It's very minimal, unless you feel like an aneurysm, which is a pulsating like a normal radial pulse. So dorsalis pedis is between the first and second metatarsal toe, and the posterior tibialis pulse is between the midway between the medial malleolus and the calcaneus bone. Now finally with the special test. This is the most important part of the examination. So always, what we are examining for in the special test, so we examine for the anterior cruciate ligament, the ACL, the PCL, the MCL, the LCL, the Meniscal Test, and the Patellar Test. So we'll start with the ACL. In ACL, it's a very common test. We have the anterior drawer test and the Ligament test. The anterior drawer test, patient is supine on bed, knee is in 90 degrees flexion. You quickly pull the upper portion of the tibia forward with both hands. You should not rotate the tibia, or the hamstrings must be relaxed in order to properly assess the ACL joint. In all specialties, you ask the patient to relax. You make sure it does not get tense, because I know because some of the movements are very can be uncomfortable to the patient. How about you ask the patient to relax and reassure him? So normally what happens is that the ACL prevents the tibia from going forward as it reaches a discrete endpoint. A positive sign is that when the tibia going forward without stop or discrete endpoint, meaning laxity or anterior translocation or ACL injury or tear, as shown earlier in the injury of the footballer who had it. So basically, this is the ACL. So we're examining this joint, and this is the anterior drawer test. So the knee is at 90 degrees. You ask the patient to place your thumbs on the tibial tuberosity. You make sure the patient is relaxed. Then you pull towards you the upper forward. And then you have a Ligament test. Patient is supine on bed, and the knee is flexed to 30 degrees angle. So you stand on the side of the patient's leg, with the patient's heel on the examination table, with one hand grasping the femur. You have to make sure you restrict the quadriceps movement, as it may mask the test. And the other hand is placed on the proximal tibia. An anterior force to the tibia, you should pull forward, as you're doing an anterior drawer test, but you're doing while the leg, you're holding the quadriceps is floating, and then you're pulling it forward. And this you should reach a maximum point, and this is a normal test. In a positive test, the tibia is going forward without stop or discrete endpoint, meaning laxity or increased anterior dislocation of the tibia, meaning either ACL injury or a tear. This is how you do a Ligament test. So the direction, so make sure your hand is applied on the quadriceps to prevent any masking and to restrict the quadriceps movement. And then you pull the knee forward, and this is called the Ligament test. Now the posterior cruciate ligament, as you know, the posterior cruciate ligament it helps in that the tibia is 1 centimeter anterior to femur condyles at 90 degrees flexion because of the PCL. There are 2 tests for it: the posterior drawer test. Your patient is supine on bed and the knee in 90 degrees flexion. You ask the patient to push the upper portion of the tibia backwards using both hands. The tibia must not be rotated, and the hamstring must be relaxed to properly assess the posterior cruciate ligament. Normally, it will prevent going backward with the discrete endpoint. A positive sign that it will go backwards without stop or discrete endpoint, meaning the posterior translocation. Could be a PCL injury or tear. Now, a posterior sac sign or a gravity drawer test, as another name for it, the patient is supine in bed and the hip is flexed at 90 degrees. The knee is flexed at 90 degrees, and the examiner stands at the end of at the side of the patient's leg, with one hand grasping the heel of the patient for support, and observe for indication of the tibia if it has translocated posterior or toward the table in comparison to the other knee. So the PCL is this ligament shown with the arrow here. So this is the posterior drawer test. As you do an ACL, just so you push it backwards. Now this is a posterior sac sign, so make sure the hip is 90 degrees and the knee flexed to 90 degrees, and you observe for a sac sign. Usually, how you can notice from the side of the leg, you can see the tibia is translocated backwards. And this is a video of the ACL and PCL test.
90 degrees. Again, we have to get the patient's permission. I'm going to sit in your foot. So we don't want to just jump on their foot because it gives them a fright. So sit on your foot. And what I'm going to do is pull first anteriorly and then posteriorly. So anteriorly, solid endpoint, no laxity there. Posterior draw, looking at the PCL Very solid, no laxity, no pain. Our next test is Lockman's test. That's a way to assess the anterior cruciate ligament. So to do that, we need to stabilize the thigh. We need to make sure Martin's nice and relaxed. And we're trying to move the tibia anteriorly relative to the femur. So we grab the tibia and we're pulling anteriorly. And we can feel a nice solid endpoint. Hopefully you can see that too.
The prevalence of PCL injury remains unknown, also due to the fact that the PCL tear often goes undiagnosed. The most common causes of a PCL tear are due to dashboard traumas, a fall on the anterior proximal aspect of the tibia with a flexed knee, or a hyperextension injury. This test can easily be progressed into the Godfrey sign, for which a posterior sag is noted in case of a torn PCL, when the patient's hips and knees are flexed to 90 degrees and the patient's heels are supported by the examiner. In this test, the posterior sag becomes more prominent due to gravity, which pulls on the tibia even.
Okay. So next we'll examine the medial cruciate, medial collateral ligament and the lateral collateral ligament, which is the sides, support the sides of the knee. There are two tests for it. For the medial collateral ligament, we do a valgus stress test. You have to be very careful at this point. When the examiner will ask you questions sometimes regarding the medial collateral ligament and the lateral collateral ligament, and which test is involving which, so to avoid any confusion. So for the valgus stress test, a patient supine in bed and the knee is in 20 to 30 degrees light flexion. Why we do that? So it will unlock the knee from full extension. يعني كأنه قفل. You open the door, so you open the door and you unlock the knee from full extension. Then you place one hand on the ankle and the other on the lateral side of the knee against the fibular head. You have to make sure at that point. While holding the ankle, apply a medial or a valgus force. So medial means pushing to the medial side, from the lateral side to the medial side, at the fibular head. And to the knee, and at that specific angle from the inside, and you repeat it of applying the medial valgus toward the medial side to the knee with the knee in full extension. You do it 2 times. You do it at 20 to 30 degrees angle and do it in full extension. A positive test when there's a gap in the medial collateral ligament, the MCL, meaning there's a deficiency in the ligament or pseudolaxism from the joint space collapse. And the medial sided pain, sometimes the patient will complain from pain. A medial side means a grade 1 injury or sprain of medial collateral ligament. When it's positive, that when the knee is in 20 to 30 degrees, means only specifically for the medial collateral ligament. However, if the knee in full extension is positive because of pain or a gap, means the MCL and one of the cruciate ligaments is injured. This is more severe, and this may lead to a terrible triad of the knee, which is a very difficult condition to treat. Then you have the lateral collateral ligament or varus stress test, almost the same as the valgus stress test. However, you apply lateral or varus force toward the lateral side of the knee when the knee in full extension and 20-30 degrees. A positive sign when the gap in the lateral collateral ligament, and the lateral sided pain without gaps means a grade 1 injury or sprain. Is a positive when the knee is at 20-30 degrees, a lateral collateral ligament injury, and the knee is in full extension. It means that lateral collateral ligament and one of the cruciate ligaments injuries are more severe, as I mentioned earlier in the medial collateral ligament. So the ligaments involved, so this is the medial collateral ligament shown in the arrow, and this is the lateral collateral ligament. Okay, and this is how the patient applying a medial force to unlock the medial collateral ligament gap. Normally we don't have a gap. However, when you have a gap or a pain, means there is an injury to the MCL. Now this is a GIF video show you the injury. Is applying a valgus force, and this is how applying a varus force for the LCL. So you do it 2 times. You make sure you do it in a 20-30 degrees angle and do the full extension. And this is a video.
So with the medial ligament, we apply a valgus stress. So first with the knee in extension, is there any laxity or pain? Then we take the knee into 30 degrees of flexion, valgus force, any pain or problems with that. And so that's rock solid. If there's laxity and extension, we're thinking a much more significant injury than if there's laxity with 30 degrees knee flexion. Similarly for the lateral ligament, we're going to take the knee in extension and a varus force, and then 30 degrees knee flexion and a varus force. And so we can feel a good endpoint, no pain or problems with those tests. If there's laxity and extension, we're thinking a much more significant injury than if there's laxity with 30 degrees knee flexion.
So this is a patient. She had, I think she was 20 years old. This is one of her from the United States. So this patient had a multiligamentous injury. As you can see, she has a positive sign of multiple. She has MCL, LCL, and a PCL. So this is a positive posterior sag sign, or the gravity sign that I showed you earlier. And she has an MCL and LCL. So she has it's a very bad injury of the knee. Now for the meniscus test, we do a test called a McMurray test. There's a typo on page 35 of the examination booklet of the Kuwait University, so make sure to check it out. In the McMurray test, always remember, I want you to remember this from now on. In a medial meniscus, flex the knee, valgus force, external rotate, extend. That's it. Lateral meniscus, flex the knee, varus force, external rotate the knee, extend the knee. You have to make sure of that. So how do you do it? So what I mean by the medial and lateral meniscus. So this is the medial. So this is the meniscus. So this is the medial side, and this is the lateral side. So this is a mnemonic. So internal rotation of the tibia plus varus test is lateral meniscus involvement. External rotation of the tibia with valgus stress means medial meniscus. And this is how you do a McMurray test. So first start with the medial side. So he's examining for a medial meniscus. So what he does, the patient is supine in bed, stand at the affected knee or the examined knee, place one hand on the heel and the other on the medial aspect of the knee, providing a valgus force. The knee is extended from fully flexed position while externally rotating the tibia. So the patient is in a flexed position. Then he externally rotate to the tibia to the outside. Remember, external rotate means I am rotating to the tibia, not the hip, the tibia to the outside. Please be careful at this point, because there have been a lot of mistakes in the extension because of the McMurray test. You have to practice this test, and also be careful while you're doing it. Don't apply too much force on the simulated patient or any family member. Otherwise, you will cause a meniscal tear and it cause problems. So a positive test means a popping or a sensation of pain. Symptoms like pain, snap, audible click, unlocking, a compromised knee along the joint line, or inability to fully extend the knee. Now the lateral meniscus is the same. The knee is flexed from the fully flexed position while internally rotate the tibia and with a varus force. Don't forget that. Then another test you do for the meniscus is called an applique compression test or a grind test. From its name, patient will be lying in the prone position on his abdomen on a low examination table. Make sure the table is lower. However, in the exam, as you should ideally mention that the examination table should be lower, and the patient should be distracted before the examination when the examiner applies his or her knee. So you ask the patient to relax, and then you apply a force perpendicular on his posterior thigh of the leg, and you after flexing the knee 90 degrees. and you do apply a perpendicular compression with external rotate or gripping the ankle. If you go externally, you're examining for the lateral meniscus. If you go internally to the tibia, to the inside, while gripping the ankle, this is a medial meniscus. If there's a compression present increase in pain, this test considered positive and possibly an injury to the meniscus. So this is a meniscus again. So we're examining this area. So this is the applied compression test. You place your knee on the patient's side in order to be distracted, to avoid any masking, and then you accordingly. So if you go external rotation, let's say for example this is patient's right leg. So externally you apply an external force while the external rotation of the tibia, not the leg, the tibia, this part. External rotate for the lateral meniscus and the internal rotate for the medial meniscus. We're applying direct force. This is how you do it basically. Downward pressure, an external rotate for lateral meniscus, and medial rotation for medial meniscus. And this is a summary of the meniscal test.
To perform a McMurray's grind, what you'll be doing is you'll be placing the patient in a supine position and flexing the hip and the knee. Next, you're going to be grasping the tibia, externally rotating, and applying a valgus stress. A valgus stress is towards the midline. For this one, you'll be applying a valgus stress, externally rotating, and slowly go into extension. Likewise, you can internally rotate, provide a varus stress, so varus meaning laterally, and then slowly extend. What you're looking for is you're looking for pain or popping, and a positive McMurray's test is indicative of a meniscal injury. So if I'm externally rotating and providing a valgus stress, you're assessing the medial meniscus, while internally rotating and varus stressing is going to be assessing for a lateral meniscus injury.
To perform Apley's test, the patient lies prone with the involved knee flexed to 90 degrees. The examiner stands on the side of the examination table with both hands on the plantar aspect of the subject's foot and heel. The examiner medially and laterally rotates the tibia while applying an axial load through the tibia. The same medial and lateral rotation should then be repeated with a distraction force. A positive test with compression is indicated by pain, clicking, and/or restriction, and may represent a tear of the medial or lateral meniscus, depending on the location of symptoms. A positive test with distraction is indicated by an increase and/or change in location of pain and is more indicative of ligamentous versus meniscal pathology.
Then you examine for the patella. You do a patellar friction test and J sign, and then you do an apprehension test. I think this is the final examination special test. So you do a patellar friction test. So I remember I always say do this: extend the knee, parallel squats, and the compress the patella. This is a mnemonic. I remember it from back during my elective in Queen's University in Kingston. We did a patellar examination on a patient in an operation because he had a patellar fracture. So we did the this patellar friction test. So the pain is elicited by rubbing the knee against the femoral trochlea, or the I showed you earlier. It's one of the main stabilizers. The trochlea is basically the groove of the femur at the femorus, or by pressing against the patella and ask the patient to contract his quadricep muscle. So extend the knee, parallel squats, compress the patella. Now for the J sign. So this is basically the patellar friction test. So you normally at the left picture, this is a patella. So this is the femoral trochlea, and this is the abnormal. Because of the abnormality at the femoral the trochlea, he has a patellar maltracking abnormality. A J sign. So the patient will be sitting at the end of the bed with the knee 90 degrees flexed. Ask the patient to extend the knee actively from a flexed position. So J sign. So at the end of the bed, knee 90 degrees flexed. Ask the patient to extend the knee actively. So ask him extend. You don't extend from a flexed position, and then you check for J sign. I'll show you in a video later on. And then an apprehension test. This is the one that patient most likely be uncomfortable with, because you're pushing you ask the patient to relax his knee and you're pushing the patella laterally. And you have to be careful to observe apprehension signs. So apprehension reaction, we call that either patellar inflammatory instability or a patellar possible lateral dislocation subluxation or MPFL injury, which one of the main stabilizers of the patella with the quadriceps femoris. So this is a summary of the patellar test.
Position yourself next to the patient on the involved side and place the web space of the thumb on the superior border of the patella. Then ask your patient to contract the quadriceps as if they were to extend the knee while you apply downward and inferior pressure on the patella. Pain with movement of the patella or the inability to complete the test is indicative of patellofemoral dysfunction and considered a positive test.
So you can see the patella has been moved in J sign.
Kudos. Dislocations of the patella are a fairly common sight in sports, and Kai has experienced it himself during his active soccer career. While these are usually traumatic incidences, genetic predisposition can play a role as well. Factors that may influence the risk of dislocation are, among others, the sulcus angle and sulcus depth. To conduct the test, the patient is either lying supine or sitting on the bench with the knee flexed to 30 degrees. The quads should be relaxed to allow passive movement of the patella. With the thumb of both hands, press on the medial side of the patella to exert laterally directed pressure. In a positive test, the patient may be surprised by the lateral displacement of the patella and feel uncomfortable or apprehensive as the patella reaches the point of maximal lateral displacement. The patient may even reach for your hands or attempt to straighten the knee to pull the patella back into relatively normal position.
To perform the patellar apprehension test, the patient lies supine with 30 degrees of knee flexion and the quadriceps relaxed. The examiner carefully pushes the patella laterally while watching the patient's facial expression. If the patient suddenly contracts the quadriceps to avoid patellar dislocation or exhibits apprehensive facial expressions, the test is considered positive for a subluxing patella.
Now we reached the end of the presentation. So what may be a common question be asked? So sometimes the examiner will tell you the scenario of this player, let's say for example, or any patient who had an ACL injury, and they ask you to manage. And how do you manage this patient? Depending on his age. If he is an active and he wants to play sports, you do an ACL reconstruction with an autograft. You're not required to know which graft you take it from, but however, you need to know that you do an ACL reconstruction, and sometimes you do a pivot stabilization, a pivot shift stabilization. As you know, because of the ACL, it's responsible for knee to preventing knee anti-translocation and with a slight rotation of the knee. So you want to prevent knee rotation and translocation. Then you had asked at the special test, and then I mentioned earlier, you asked the neurovascular status questions in every orthopedic examination. And this is the end of the presentation. Thank you for your attention. If you have any questions, ask them in the comments down below, or send me an email to orthopedicsart@gmail.com. I'll be more than happy to answer. Thank you so much for your time. Wish you well and good luck in your upcoming OSCE exams. Bye-bye.